prerequisite talk. So we have two of our fantastic residents speaking this morning. Justin, are you going first?
It looks like it, yep.
Justin Nguyen speaking on the management of adolescent varicoceles. And then Stephanie Hanchuk, I see you as well. Good morning. Vaginal estrogen, what every urologist should know. So do we have any announcements or anything else to start off our CME event, Grand Rounds? All right, good morning, Justin. Take it away.
All right, good morning, everybody. I'm Justin Nguyen, and in honor of my pediatric rotation, I'll be presenting on the management of adolescent varicocele, focusing on intervention versus observation. So I have no financial disclosures. As a brief overview, varicoceles are an abnormal dilation of the panpiniform plexus. The etiology is thought to be due mostly to anatomic, as well as incompetence or absence of venous valves. Advance. The prevalence of varicoceles in the general population is about 15 to 20%. In the pediatric population, they really start to arise around puberty, and by age 15 to 19, they're around the same as the general population. Advance. Varicoceles are associated with infertility. Varicoceles are prevalent among 35% of men with primary infertility and 80% with secondary infertility, although the majority of men are actually fertile, with about 85% of men with varicoceles being fertile. Varicoceles are associated with impaired testicular function. They're associated with decreased testicular volume and abnormal sperm parameters, although the exact impact of varicocele on fertility is controversial, and only clinically palpable varicoceles have been clearly associated with infertility. Advance. The pathophysiology is unclear, although some theories include hyperthermia, reflux of adrenal metabolites, tissue hypoxia, and potentially hormone imbalances. Advance. A good evaluation of a varicocele includes history, a good physical exam, potentially ultrasound with Doppler, semen analysis, and endocrine evaluation. Next. For varicocele grading, subclinical varicoceles are visible on imaging but not palpable on exam. Those are usually not considered very important. Really, grade 1 is palpable with Valsalva, grade 2 are palpable at rest, and grade 3 are visible and palpable at rest. There's no direct correlation between semen parameters and grade in adolescents, although there has been correlation between grade and testicular hypertrophy. Grade alone is not an indicator for intervention. Next. The prevalence of varicocele-associated ipsilateral testicular hypertrophy is about 9% in adolescents. They recommend using a consistent method, either orchiometry or ultrasound. Here's some orchiometry beads I found on Amazon. But most importantly is really testicular volume differential. Significant testicular volume differential for most is about a 20% difference. Some studies say around 10 to 20% or a 2 to cc differential. Next. Other things you could consider getting is a Doppler ultrasound. Some studies have shown that a peak retrograde venous flow greater than 38 centimeters per second is associated with unlikely catch-up growth. Semen analysis is a mainstay in adult men, but the normal ranges have not been defined in adolescents, and they just use the WHO standards for adults. And there are ethical and practical considerations that really limit its use. And then no real consensus on endocrine evaluation, although you could consider getting an endocrine panel. Next. So the main goal is really to preserve fertility while avoiding unnecessary intervention, with two main options, either observation or varicocelectomy, of which there are various approaches. Next. The American Society of Reproductive Medicine and Society of Male Reproduction and Urology guidelines in 2014 said, adolescents and young men not actively trying to conceive who have a varicocele and objective evidence of reduced ipsilateral size may be offered varicocele repair. Also, if they have abnormal semen parameters, they note that catch-up growth and reversal semen abnormalities has been demonstrated. And And if there's no evidence of testicular damage, they say that they should be followed with annual measurements or semen analysis. Importantly, they note that data is lacking regarding the impact on future fertility. Next. The European Association of Urology notes that while the presence of varicocele is associated with testicular damage and reduction in fertility, there's a significant risk of overtreatment, with the majority of boys with varicoceles will having no fertility problems later in life. They also recommend treating adolescents with ipsilateral reduction in volume, as well as progressive testicular dysfunction, such as impaired semen parameters. Next. So why is the management of adolescent varicoceles controversial? First is the majority are asymptomatic, and unlike adults who are often presenting with fertility issues, adolescents, their future fertility is pretty much unknown. Most of them are not trying to have kids, and 80 to 85% of adults with varicoceles have no paternity issues at all. Most studies use surrogates for fertility, not paternity itself, mostly focusing on testicular volume as well as semen parameters. But there are conflicting studies on testicular catch-up growth after varicocelectomy. While volume differentials greater than 10 to 20% have been associated with increased risk of persistent or worse asymmetry, other studies show 50 to 80% of volume discrepancy will resolve without surgery. Also, while testicular volume differential has been associated with decreased total sperm counts, and varicocelectomy is associated with improved semen parameters, some argue that this is only transient. On the other hand, if you were to delay repair, there's no improvement seen in semen parameters in 30% of adults who get varicocelectomy, and testicular hypertrophy usually does not improve in adulthood. Next. So this was a survey of all pediatric urologists, part of the AAP in 2014, looking at their management of asymptomatic grade 2 to 3 varicoceles. Next. And it really highlights some of the controversy. So if you have a patient with a significant size discrepancy and 85% classified a volume differential greater than 20%, 33% said they would immediately intervene, while 59% said they would actually observe and get repeat measurements. If they were already following a patient with an asymptomatic grade 2 to 3 varicocele, 37% said they would discharge after yearly follow-up, 23% would refer to an infertility specialist, and 30% would evaluate with semen analysis. Notably, 60% of pediatric urologists don't ever get a semen analysis in this survey. Next. This was another survey published in the Gold Journal the same year, and they asked this question, if an asymptomatic 15-year-old boy presents with a grade 2 varicocele, left testes smaller than right testes appropriate volume for age, no inguinal discomfort or pain, how would you manage this? Next, 58% would get varicocelectomy now, and one more, click, while 46 would observe. And so you can see half and half would go one way versus the other, really kind of highlighting this controversy. Next. So, the main indications for intervention is really future fertility, of which we use surrogates, testicular hypertrophy, volume asymmetry, abnormal semen parameters, and then clinical indications such as pain or cosmetic reasons. I'm not going to focus much on those because they're less controversial and really focus on the fertility issue. Next. So first, looking at adolescent varicocele and testicular volume, this was a meta-analysis published in the Gold Journal in 2012, looking at the association between volume discrepancy after varicocele treatment, and it had one perspective and 13 retrospective studies. Next. And they found that for patients with both a 10% and 20% volume discrepancy, that after varicocelectomy, up to 76% had significant catch-up growth. Next. This next study is then comparing patients with, it's a randomized control trial with looking at patients with clinical varicocele who are then treated with inguinal varicocelectomy versus observation. Next. And they broke the patients up into two main groups. Group A had testicular volume differentials greater than 20%, and all of those patients were managed with varicocelectomy. And then Group B, those patients had volume differentials less than 20%. They were randomized into two groups. Group B1 got varicocelectomy. Group B2 were observed. Next. Looking at the intervention groups, similar to the first study, both intervention groups showed catch-up growth in the 70% for Group A, 74% for Group B, and they found no significant difference in catch-up growth regardless of grade. Next. Comparing that to the observation group only showed a catch-up growth of 50%, and they actually showed that catch-up growth was significantly better in lower grade varicocele. So grade 2 had a 61% catch-up growth versus 40% in grade 3. And so they showed catch-up growth was significantly better in the intervention group versus observation. Despite this, they found no significant difference on final mean testicular volume between the two. Next. Then looking at adolescent varicocele and semen parameters, this is a meta-analysis published in the journal Fertility and Sterility in 2014. It looked at use age 15 to 24, and they performed two meta-analysis, one on the effect of varicocele on sperm parameters, and two, the effect of varicocele treatment versus observation on sperm parameters. Next. The first meta-analysis had 10 studies, 9 prospective, 1 retrospective, no randomized controlled trials. They found that varicoceles were associated with decreased sperm density, decreased sperm motility, and decreased sperm morphology with no effect on volume. Next. This is a forest plot showing varicocele associated with decreased sperm density. Next. And varicocele associated with decreased sperm motility. Next. The second meta-analysis also included 10 studies. 2 of these were randomized controlled trials, and they found that with treatment versus observation, varicocele treatment was associated with improved sperm density and improved motility versus observation with no effect on morphology or volume. They also did a subgroup analysis looking at different surgical approaches. The Palomo technique showed improved sperm density, no effect on motility, and the inguinal, subinguinal showed both improved sperm density and motility. Embolization, they weren't really able to comment due to a lack of studies. They only had one. Next. This is a forest plot showing improved sperm density versus observation. Next. And improved sperm motility in the treatment group versus observation. Next. So what about paternity, which is really the gold standard? There are very few studies in adolescents, no randomized controlled trials, but I was able to find 2 studies. Next. The first is a single center retrospective study published in the Journal of Urology in 2013 that looked at 11 to 18-year-olds who underwent antegrade sclerotherapy versus observation. They contacted these patients after they were 30 years old. It's a survey, so there's a lot of bias here, only a 54% response rate. Next. But what they found was there was no difference in paternity between the patients who got treatment versus the patients who did not. But significantly, 92% of them did not have a significant volume discrepancy. Next. So they just did a subgroup analysis of the patients who did have a volume discrepancy greater than 2 cc's. And once again, they found no difference in paternity rates between the two groups, with an incidence of about 8 to 7% of volume discrepancy, which is pretty, which is comparable with the standard population. But you can see the groups are very small. There were only 17 patients in the treatment group with a volume differential that was significant and only 10 in the non-treatment group. Next. So this next study was a single center prospective study published in the Journal of Urology in 2017. This had 408 patients between 12 to 19 years old with a clinically palpable varicocele, and they all had an absolute indication for intervention, either a significant volume differential or abnormal semen parameters. 286 underwent microsurgical repair versus 122 who were observed. Next. And while most of their baseline characteristics were the same, it is important to note that the mean follow-up time was longer in the varicocelectomy group versus the observation, potentially introducing bias, as well as a higher incidence of bilateral varicocele than would be expected, up to 63% in the microsurgical versus 53% in the observation. Next. They found that there was a significant difference in paternity rate between observation and intervention, 78% versus 48%. So in addition to this, the microsurgical group also had a shorter time to conception, 11 months versus 17 months. Next. They also looked at semen parameters, and they found that sperm concentration and motility significantly improved in the treatment group. Interestingly, they also found a significant difference in total testosterone. The treatment group had higher testosterone. This is one of the only studies I found that actually showed a difference in this. And their complication rate was low, only 1.4%, no hydrocele or testicular atrophy. Next. Finally, they did a multivariate analysis looking at potential predictors of paternity, and they found that varicocele surgery and semen parameters were positively associated with improved paternity versus the need for additional treatment being negatively associated. Next. So looking at different varicocelectomy techniques, there's really surgical versus radiologic approaches, and there's many different approaches with various variations. I'm not going to spend too much time going through the nuances. Next. But I found this this really nice meta-analysis. It's really in the adult population, but it does a good job looking at the different pregnancy, recurrence, and hydrocele rates among the various techniques. It included 36 studies, and the goal was really to identify the best technique. Next. And they found that the microsurgical technique was associated with the best pregnancy rates. Next. While looking at the risk of recurrence and risk of hydrocele, you can see there's a very large variability in risk of recurrence and hydrocele between the different techniques, but the microsurgical was associated with the lowest risk of recurrence and hydrocele, which has made it the gold standard in adults. Next. But interestingly, in the pediatric population, the most popular technique is actually laparoscopic versus microsurgical. And some theories are that pediatric urologists are more familiar with laparoscopic technique. In addition to this, there are also some techniques, different approaches that can be used to make laparoscopic, that can reduce the risk of hydrocele in laparoscopic. Next. Including using dye-assisted lymphatic-sparing laparoscopic varicocelectomy. This is one study published by Globusky, where they did a randomized controlled trial looking at grade 3 varicoceles. And they found by using this dye-assisted technique, they could identify the lymphatics 88% of the time. And in their study, they actually had a 0% recurrence and a 0 hydrocele rate in the lymphatic sparing approach versus 14% in the non-sparing. This is actually much lower than what's normally quoted. Esposito, they came up with a new technique where they actually do the standard intradartos injection plus an intrascrotal injection, and they were able to improve their lymphatics identification from 75% with the classic technique to 100% with their technique, and also had a very low hydrocele rate, 0 versus 8%. Next. So finally, this was a great meta-analysis published in European Urology just recently, 2019, that looked at all randomized controlled trials, non-randomized comparative studies, and case series involving more than 50 patients, with patients under the age of 21 with a clinical varicocele, really trying to compare intervention versus observation. Next. They found that testicular volume was significantly higher in the treatment group versus observation. They also found that sperm concentration was significantly higher in those who were treated versus observed, although they didn't find a significant difference in motility or morphology. Next. Looking at paternity rates, they weren't able to find any randomized control trials. They looked at the same 2 studies we discussed earlier, and ultimately they felt that the effect of surgery on paternity rate could not be determined in adolescents due to the significant bias in the studies and the lack of availability of higher quality studies. Next. They looked at open versus laparoscopic surgery, and they were not able to identify a superior surgical technique due to the lack of randomized controlled trials. But they noted that both the open and laparoscopic seemed to have similar treatment successes. All of them were over 85%. And when they looked at the lymphatic sparing approach, just like we were talking about earlier, the lymphatic sparing was associated with significantly decreased hydrocele rates. Next. They also found that in the majority of studies, hormone levels were normal before and after treatment, so really no effect on hormone levels. And all studies reported 90% pain resolution after varicocelectomy. Next. So conclusions, varicocelectomy is associated with improved testicular volume and catch-up growth compared to observation. Varicocelectomy is associated with improved semen parameters compared to observation. The effect of varicocelectomy on paternity remains unclear. Randomized controlled trials are needed to further evaluate. And there's a large variability in recurrence and complication rates among the different varicocelectomy techniques. The microsurgical technique is associated with the best outcomes, and the lymphatic sparing approach reduces the risk of hydrocele. Questions?
Justin, that was great. I just have a quick question. For most of those studies, we think about having 2 interval time periods for the criteria for meeting a 20% differential and needing surgery. Were some of those on just 1 time point, or are most of those over 2 time periods?
There's a lot of variability between the studies. They use different cutoff rates and different, some of them did require, multiple time points showing that there was a volume discrepancy. Other ones didn't really specify. A lot of the studies didn't go into the details of really fully defining that.
Justin, that was a great job, Justin. Thank you for the talk. One thing, we've done some varicocelectomies together, and I flip between laparoscopic and open. And one thing that we can address both laparoscopically and through embolization is kind of the extraspermatic vessels, the ones outside of the specific cord, outside of the premasteric. Any discussion about that? Because that can all be addressed through a subinguinal approach or an inguinal approach to get those other vessels. I guess Dan can also weigh in if he thinks there's value in those vessels, but some people argue that may contribute.
Yeah, I did see that mentioned a lot. That a big advantage of doing the microsurgical approach is.
Yeah, I think that this Stan.
Yeah, go ahead, Dr. Honig.
Can you hear me?
Yes, we hear you. All right, Justin, why don't you finish your thoughts? Dr. Honig is fixing his connection.
Okay. Yes. Yeah. So the microsurgical approach, was associated with the best outcomes. They did note that one of the things that was, not only with the microsurgical approach could you identify the lymphatics, but you were also able to get, like you're saying, peripheral lymphatics, outside of just the cord, which
not lymphatics, veins.
Oh, veins, right? Sorry, veins. That's what I meant. Sorry. I meant veins. Yeah, you're able to get veins outside of the cord, which they thought might have improved the outcomes with recurrence rates.
Yeah, I think that, Justin, you did a great job reviewing that. And I think based on what you said, it's pretty clear that we really don't know what to do here. Okay. Number one. Number two, I think this really becomes an emotional decision. So you're in practice, you're 4 hours from a major health center, and a 16-year-old comes in with an asymptomatic palpable varicocele and 15 to 20% drop in volume. What are you going to tell that guy? What are you going to tell the patient? What are you going to tell his parents?
Yeah. I mean, it seems they have a significant difference in volume. I think one of the hardest things a lot of these kids you can't get semen analysis on, just because of those ethical considerations. I can see that it's tough because while a lot of these kids will be fertile in the future, at the same time it's hard to know for sure. And I think if there is a significant difference and there's a concern for future fertility, I think it's very reasonable to offer varicocelectomy and kind of reduce that risk. But yeah, it's a tough question.
I mean, I would argue almost that most 16 to 7-year-olds can give you a sample, okay? And if they can't, you can make an argument to wait a year and see if they can give a sample. Now, you can make an argument that you're going to lose testicular size, things like that. A lot of this is just driven by the parents and, you know, their hopes for their children and grandchildren, things like that. So I think based on the data, you could go either way on this stuff, and you really have to kind of just make a shared decision-making discussion with the parents and the child. And I try to wait for a semen analysis if I can. If it looks okay, I'll say, hey, come back in a couple of years. Just make sure there's no deterioration. If it's borderline, I kind of leave it up to them. And if it's low, I'll recommend fixing it. And for those that can't give a specimen, which is probably maybe 20%, I would think, and obviously it depends on the child, and you can wait a little bit, then those are the ones that you have to kind of leave up to them as to what you should do. But I would lean towards fixing it if you can't get a semen analysis.
Are you doing serial semen analysis, Dan? If you see them at 15 and then 18, they're normal, you repeat it again, or you just say wait till you have problems as a?
No, I say come back in a couple of years. I say if they're 18, I say come back in a couple of years and check it again. And there's a point where we stop or they just don't come back. But they know about it, and you know, they think about it so that when they're an age of, you know, fertility, they're going to maybe come in at 6 months as opposed to a year and kind of figure out what's going on from there.
Hey, Stan, can you hear me?
Yes, is this Izzy?
Yeah, it's Izzy.
Oh, no.
I don't disagree with you. I don't disagree with you at all. I think in these patients that have, you know, even size discrepancy, since the data shows that there's catch-up growth in just about all of them, there's never really any severe urgency to go operate on them. I think actually the most recent work done by the group in Pennsylvania shows that if you have a volume of less than 30, a total testicular volume less than 30 cc's, almost invariably those patients have abnormal semen analysis, and some of their hormone levels are abnormal, while the ones who had a total volume of greater than 40 cc's all had normal sperm counts. So it appears that, you know, you can wait if they're in, you know, and try to see if they go from 40 to 30 clearly and drop below that 30 cc volume, the likelihood they're going to be abnormal is pretty high. The other thing is if you look at the literature and the timing, we predated doing these lap varicoceles with dye and published, you know, some of the earliest series on those. There's no need to use dye to identify the lymphatics laparoscopically. And the other thing is, if you look at microvascular varicocelectomies in young boys, the incidence of infarction of the testicle and total loss of the testicle is much higher than the adult literature. And that is just because of the difficulty in identifying the artery in younger patients. And it's clearly easier in fully grown adult males, but it's much harder in a 13 or 14-year-old male who has a significant difference in volume. And I think that's one of the things that you left out of your talk, Justin, that is very important.
You know, it is interesting because I saw that argument, and I did see a study that talked about the ability to identify the artery in depending on age, and I didn't include it in the talk mostly because of time, but they were saying they kind of tried to debunk that the ability to identify the artery is the same regardless of age. But I did see a lot of I saw that was very commonly cited as a reason why the microsurgical approach was less popular in the pediatric population then.
My name is Stephanie Hanchuk, and today I'm going to be talking about vaginal estrogen, what I feel that every urologist should know about this topic. The outline of my talk today is talking about the role of estrogen in the urinary tract, the pathophysiology of hypoestrogen states, evidence for supplemental estrogen use, relative contraindications to this use, as well as finally practice recommendations. Estrogen is most well recognized for its development and regulation of the female reproductive system. However, we know that it also has numerous systemic effects, including but not limited to bone density, fat storage, hypercoagulability, cardiovascular health, and anti-inflammatory properties. The relationship of estrogen and urinary tract health is one of great interest in the urologic community, as its potential as a therapeutic agent is great. Estrogen receptors have been shown in biopsy specimens from all the way from the bladder trigone, urethra, vagina, and pelvic conductive tissue. Estrogen is necessary for the health of these tissues, as evidenced by the atrophic changes in the vulvar, vaginal, urethral, and bladder tissue that occur in hypoestrogen states after menopause. As you can see here, the mucosal and stromal tissues all contain estrogen receptors, and they undergo significant atrophy when estrogen deficiency occurs. This consequent decrease in vaginal tissue leads to a loss of elasticity and decreased fluid secretion, which predisposes women to trauma and pain. Women who suffer from atrophic vaginitis on exam generally have paler vaginal epithelium, loss of rugae, labial fusion, shrunken urethral meatus, as well as a narrowed introitus and shortened vaginal length. Beyond just local tissue changes, estrogen deficiency also favors a more alkaline vaginal pH, more basic, which inhibits the growth of lactobacillus, a natural vaginal flora, and increases the growth of gram-negative uropathogens, which can then in turn lead to increased UTI risks. So how do we overcome these inevitable changes in a woman's life? We can utilize supplemental estrogen. The vagina is a highly vascular organ, which makes it actually perfect for drug absorption. One of the major advantages of vaginally administered drugs is avoiding first-pass hepatic metabolism. This results in the ability to use lower doses of the drug to achieve an equivalent therapeutic effect. Systemic reviews have concluded that there's insufficient evidence to support one formulation over another. Therefore, prescribers should allow patient preference and ability to manage their treatment to dictate the modality. As you can see here in this table, taken straight from the AUA guidelines, there are three most commonly used vaginal estrogen therapy formulations here. There's a vaginal tablet, a ring, and a cream. The tablet and the cream need to be used by the patient 2 to 3 times per week to guarantee effect, whereas the vaginal ring is implanted either by patient or provider and needs to be changed once every 3 months, which can also be done by the patient or the provider. Currently, the AUA has one indication in their guidelines for the use of vaginal estrogen. The guidelines for recurrent UTIs state that, quote, in peri and postmenopausal women with recurrent UTIs, clinicians should recommend vaginal estrogen therapy to reduce the risks of future UTIs if there is no contraindication. They list this as a moderate recommendation with grade B evidence. As you can see here in the recurrent UTI algorithm, vaginal estrogen therapy is recommended as a first-line therapy for the index patient alongside antibiotic prophylaxis. In the guidelines discussion, they also highlight evidence showing that oral estrogen has not been shown to reduce UTI recurrence rates. Therefore, women who are already on systemic hormonal therapy should also be additionally initiated on vaginal estrogen therapy. The evidence for this is presented in a recent Cochrane review on estrogen use for preventing recurrent UTIs. They examined 5 double-blinded randomized control trials related to vaginal estrogen use. 3 of the studies compared it to placebo, 2 of the studies compared it to oral antibiotics. There are many significant findings in the placebo control trials that were quite impressive. They showed both decreases in UTI rates and vaginal pH, no increases in adverse effects compared to placebo, and an increase in lactobacilli positive cultures. The studies that were comparing vaginal estrogen to oral antibiotic use were rather mixed. Raz et al. Had reported a study that showed significantly less UTIs in the antibiotic prophylaxis group, but then came along a larger study out of China of Zhu et al., which reported less UTIs in the vaginal estrogen group. So right now, the results are mixed to compare vaginal estrogen to prophylactic antibiotics. So moving on past recurrent UTIs, we have probably a more even prevalent issue for postmenopausal women as genitourinary syndrome of menopause. Notably, the AUA does not have their own guidelines to address this issue in many of our female patients. We then rely on guidance from ACOG, the American College of Obstetrics and Gynecology, and the Endocrine Society to direct management. The ACOG Bulletin on Menopause cites level A evidence for the use of estrogen for vaginal atrophy and genitourinary syndrome of menopause. So the average age in the United States of the onset of menopause is 51 years old. With a decrease in estrogen levels, approximately 40% or 4 out of 10 women will suffer at least one symptom that falls under this umbrella of genitourinary syndrome of menopause. What are the symptoms? Symptoms can include anything from dysuria, urgency, frequency, recurrent UTIs, vaginal dryness, burning, itching, and dyspareunia. The negative impact on quality of life for those affected is substantial. Unlike the transient vasomotor symptoms commonly associated with menopause, the genitourinary symptoms do not spontaneously regress. Rather, they tend to persist and even progress with aging. As the current life expectancy of an American woman is 81 years old, that means that more than 35% of a woman's life is, quote, postmenopausal, leading a significant portion of her life to be affected by these symptoms and their adverse impact on sexual interest, intimacy, mood, and self-esteem. The meta-analyses looking at vaginal estrogen therapy for patient symptoms and genitourinary syndrome of menopause are astounding. A meta-analysis that included 10 randomized placebo-controlled trials has repeatedly shown benefit of this therapy for improvement in patient-reported symptoms. As you can see here, rarely do we see a meta-analysis where all studies agree with clinically and statistically significant findings of an improvement for a treatment. They also showed a statistically significant change in vaginal pH and cytological findings. Furthermore, they went on to address in the study that the vaginal route of administration of estrogen has been correlated with patient reduction in these symptoms, but the oral route has not been, which goes back to what the AUA described with recurrent UTIs, that the oral estrogen has not been shown to reduce rates, whereas vaginal does. So here they don't make a comment whether you should initiate vaginal estrogen on top of oral estrogen, but it is a thought showing that you don't see the same effects with the oral route. So moving on, what about urinary incontinence? So far, the data has really been plagued with mixed results. There has been basic science evidence showing that local estrogen therapy can lead to increased urethral closing pressures and decreased uninhibited bladder contractions or detrusor overactivity. With those findings, there was thought that, hey, maybe vaginal estrogen will also be useful for urinary incontinence. Unfortunately, the data has not proved as promising. So in a Cochrane review in 2009, they looked at both effects of oral and vaginal estrogen on all forms of urinary incontinence. For oral estrogen, they looked at 10 randomized controlled trials looking at over 6,000 women on oral estrogen, and they showed actually an increased risk of 1.32, that's statistically significant, of any type of worsening incontinence with women in the treatment group, with a distinctly elevated risk of adverse effects. Note that all women, or most women included in these studies, had had a past hysterectomy, which may impact their levels of incontinence. Turning to vaginal estrogen, they looked at studies that included almost 1,500 women, and they showed a decreased relative risk of incontinence compared to placebo. The issues with these studies is that there's a very low quality of evidence currently due to extreme statistical heterogeneity. They had difficulty combining study data due to really distinct variation in outcomes reporting and different types of testing utilized. The adverse effect here, you see a relative risk of 1.3, although it was not significant, with a moderate quality of evidence. So as I said prior, the data out there for using this on urinary incontinence is still out there, but if it's a patient who suffers from genitourinary syndromes of menopause and has some incontinence, it might not hurt to see whether they'd have an improved effect on their overall ability to stay dry. So last but not least, what about pelvic organ prolapse? So in this sphere, there is extremely limited data. the role is even more conflicting. In theory, again, the use of estrogen has been hypothesized to potentially improve the strength of the muscles, ligaments, and fascia, providing pelvic floor support. Although the basic science laboratory data in this hasn't been as promising as in the other cohorts. Although vaginal estrogen is routinely used with pessary care and prior to urogynecological surgery, there is no good randomized control trial evidence that vaginal estrogen use decreases adverse events in either groups. The bottom line here is we need more randomized control trials to provide evidence to see if it has, one, any role in the effect of symptomatic prolapse. We, aren't going to be fooled and say that placing vaginal estrogen on a woman with grade 3 or 4 prolapse is going to change, but it may change her symptoms. And I think that's what's greatly important in these disease processes that we talk about is for patient comfort. And then the question too about concomitant use of pessaries is really a very common practice in urogynecology, but has no support in data. So the question that you guys all are probably asking now is, what do we do with the non-index patient, or the patient who has a higher risk of suffering adverse effects from using supplemental estrogen? So I'm going to present this case, and this was a patient that we were consulted on last week actually in the hospital. So this was a 73-year-old female with a history of neurogenic bladder, severe urge urinary incontinence, and recurrent UTIs. She had past medical history of paraplegia secondary to a T8 epidural abscess, hypertension, congestive heart failure, obstructive sleep apnea, pulmonary hypertension, atrial fibrillation, T1 rectal cancer, and importantly, breast cancer. She was initially diagnosed in 1990. She had undergone bilateral mastectomy and chemotherapy, and she has been cured with no evidence of disease for so long that she no longer even follows with an oncologist. For a chart review, she had 4 culture documented UTIs in the last 12 months, and she's currently admitted to the hospital with urosepsis. Urology service was consulted for recommendations for recurrent UTI prophylaxis. So how do we best address these patients? Well, I'm going to put this in some context. In 2003, there was publication of the Women's Health Initiative trial, which showed an increased relative risk of 1.26 of developing breast cancer for any postmenopausal woman taking estrogen plus progesterone therapy. This then created a frenzied reaction in the media and a diffuse ostracism in both the medical community and the lay public against using estrogen supplementation for fear of breast cancer. ACOG, the American College of Obstetrics and Gynecology, first addressed this in 2016, reaffirmed their statement in 2020 to address the safety issues on the use of vaginal estrogen in any woman with a history of hormone-sensitive breast cancer. The main points are summarized above. Really importantly, I want to drive home that vaginal estrogen should be used as a last line option in these women after they have failed all other non-hormonal options. And most importantly as well, the decision to use vaginal estrogen should be made in coordination with the patient's oncologist. I think the key here really is patient education. It's important to explain how vaginal estrogen delivers a low dose of hormone to a local environment with minimal systemic absorptions. Studies have additionally shown that vaginal hormone therapy actually doesn't result in any sustained increase in serum estrogen levels. They show that actually women on vaginal estrogen supplementation have serum estrogen levels within the normal menopausal range. That being said, the big critique of these studies is that the measurement of serum estrogen levels is very controversial. There's actually newer studies coming out using radioimmunoassays to detect even down to picogram level differences in estrogen levels to understand this further. For patients with high anxiety or concern about these issues with a multitude of genitourinary complaints that are refractory to other treatments, you may try to recommend to them a vaginal ring or tablet, as these two have shown to have the lowest rates of systemic absorption and less variability in dosage compared to vaginal creams. Additionally, these two, the tablet and the ring, are actually shown to be less likely to cause abnormal uterine bleeding, breast pain, or perineal pain when compared to vaginal creams, as discussed, with probably the lower levels of systemic absorption. In conclusion, the American College of Obstetrics and Gynecologists have decided that low-dose vaginal estrogen creams can be discussed and given to breast cancer patients with bothersome urogenital symptoms, as evidence has now shown that both short and intermediate term treatments are effective and safe. So you may be asking yourself, well, I'm concerned about breast cancer, but what about the other impacts of supplemental estrogen? So there is additional concern for the unopposed estrogen effect on endometrial tissue. As we all know, estrogen can feed endometrial proliferation. There's large multi-center studies that have shown actually no statistical difference in uterine hyperplasia or malignancy on biopsies that were performed to assess the presence of this within 6 to 12 months of either estradiol tablet or estradiol ring use. However, there is one kind of low quality study that suggested a non-significant increase in endometrial thickening with the use of estrogen cream. So the question has been raised whether women who we put on long-term vaginal estrogen therapy should have any surveillance of their endometrial tissue or any consideration of adding progesterone use to overcome this unopposed estrogen effect. Thus far, though, the data points to no. Endometrial screening is costly and has very low specificity, and currently the risk of estrogen-induced endometrial cancer is undefined. A group from Cleveland Clinic actually sought to answer some of these questions with a single institution retrospective cohort study recently published in 2020. They looked at the association of vaginal estrogen use for genitourinary symptoms in patients with a history of uterine, cervical, or ovarian cancer, with their primary outcome being cancer recurrence. This study actually comes on the back of multiple reviews in the GYN literature suggesting that actually systemic estrogen therapy may be suitable in some of these patient populations. So over a period of 26 years, they included 244 patients who, as I said, had a history of endometrial, cervical, or ovarian cancer and had used vaginal estrogen for any time period longer than 1 month. Median follow-up for these women was 6 years. Although a few critiques of the study include that they did not have their own control group to compare to, the adverse event rates are comparable to previously published values in the literature. The crux of this, though, is it was difficult to analyze the data as many of those women have multiple medical comorbidities and numerous had very high-grade cancer diagnoses with not insignificant baseline recurrence rates. So the rates here aren't minimal. Overall, the authors of this study concluded that vaginal estrogen can be safely used in some of these cancer survivors to address genitourinary symptoms, although they did not provide any specific guidance as to the proper patient selection. So last but not least, what are the practice recommendations from this discussion? After my literature review, I believe that everyone should be considering to utilize vaginal estrogen as a first-line therapy for an index patient with recurrent UTIs, as well as genitourinary syndrome and menopause. I really think here patient education is paramount as we've discussed the many issues and concerns related to vaginal estrogen use. Additionally, many women may be reluctant to address these issues. So because there is a dearth of patient education about the genitourinary changes of menopause, many women know about the vasomotor symptoms and know what to expect in that light, but don't expect the effects on their urinary tract. Additionally, patients also may be very fearful of side effects, as I mentioned, of hormone therapy. Most commonly reported in patient surveys is patients eliciting concerns about developing breast cancer, strokes, and clots, and not understanding the difference between what a systemic estrogen therapy has an effect on their body versus the local vaginal therapy. And last but not least, what do we do with the patients that have a history of breast or gynecological malignancy? It really is shared decision-making at its finest between yourself, the urologic provider, the patient, and their gynecologic oncologist. Thank you.
Yes, baby.
Stephanie, it's Marianne. I just want to make one comment that I think is helpful when you talk about using vaginal estrogen in women. So there's a lot of applications of vaginal estrogen. There's the tablets, there's the ring, there's the cream. So in terms of safety, especially in postmenopausal women, there are studies that show that there's a very, very slight increased risk of any kind of systemic circulating estrogen if you use, if you're actually using the ring. I think it's something you can see circulating estrogen at a very low level within the first 24 to 48 hours. If you're using a gram applicator, you can see that also within the first 24 hours. But if you just apply the estrogen cream by fingertip, there's actually no evidence to suggest there's any circulating estrogen levels. So that's really the safest way to apply it in the breast cancer patients, but it's also probably the most effective for women with vaginal and choroidal atrophy who suffer from dyspareunia as well as their urinary tract infections. So I just think that's an important thing. Like when you talk about vaginal estrogen therapy, there's all kinds of applications, but the fingertip application is actually probably the safest.
Thanks, Dr. Passarelli.
Stephanie, that was a great talk. I'm going to ask a question that may be a little bit naive, but when you said they were going to do endometrial surveillance, is that hysteroscopy, or can that be done with imaging? I mean, you said it was
So I think they can do a transvaginal ultrasound to look at the endometrial lining and the thickness, and then to actually do an endometrial biopsy is a little bit more invasive, and that's why they were getting into it being costly and actually low specificity. I mean, I would kind of equivalent it to just going in and doing a random bladder biopsy, right? You're just taking a swab, and they don't even visualize. They're, my understanding, just taking a random sampling of cells.
But mostly it's imaging. It's transvaginal ultrasound.
That is what they discussed. Very few studies have actually done any of this because it is costly and timely, and much of this data has not supported having to screen these women. And that would be a huge burden, I think, to introducing that therapy if that would needed appropriate screening in that light.
Right,
could I ask a question? Oh, sorry.
Go ahead.
Could I just ask a general, does anybody have any tips on getting this stuff like approved or paid for? I use it on almost everybody, but I get a very common complaint that it's extremely expensive. We tried sending people to like compounding pharmacies and haven't gotten feedback on that, but if anybody has any better ideas.
Well, I can say in my experience, Adam, that it's very difficult to get it paid for, but I think depending on the application use, I think the cost of the tube can sometimes run up to $300. You can use the 340B Walgreens. You can sometimes try the GoodRx, but if you tell the patient that this tube of cream is going to last them for 6 to 9 months, if you're only using a small amount of application, then sometimes they can swallow that cost. Because if you amortize that over months, it's not quite as expensive as it seems.
So one of those tubes should last about 9 months or so?
Well, if they're only using the fingertip application, like that's,
okay.
I usually tell people like you put the cream on by fingertip application twice, 2 to 3 times a week. And
okay.
that
Yeah, I'll talk to them about that, because usually what happens, they go to the counter, they say $300 please, and they say no and walk out and never take it.
If insurance doesn't cover it, that is about the best way to like make it.
I'm off mute, by the way.
All right, if there's no other questions, we're almost on the hour. Thank you all for attending. Great talks. I also want to just reach out to a lot of our guests that are coming both from around the state, and actually we have some international visitors as well. And it's nice to see some of our partners from the Uganda Urology group joining us. So we encourage everyone to attend, and it's nice to see so many friendly, I don't say faces because I can't see you, but names on the list. So thank you all.
Thanks, everybody.